So I think we can start.
Yes. Hello, good afternoon. Good afternoon, everybody. I think we should start. I am Antonio Pina from Cleveland Clinic, Florida, Western. And this is my good friend that will go. Pinto Marquez.
Nice to have you here all.
So it's a debate. So the two debaters will talk first, and then will not be slides for rebuttal, but the chairman here would like to have a lively discussion at the end, and the real debate. So let me start to introduce first Peter Kingham. He's a New Yorker surgeon. He's associate professor at the Memorial Sloan Kettering Hospital. He's a true New Yorker. I went through his CV. His practice has grown up in New York.
Yep.
I'm really serious.
All within,
I know.
within 1 hour of here.
Very good. Okay, so the floor is yours, and you will support hepatic artery pump versus liver transplantation. I think you are supporting hepatic artery pump.
Yes.
Okay.
You can change here. That's okay.
I may, since we're friends. So actually, Roberto and I are friends, so it's always hard to debate someone you're friends with. In order to get fired up for this debate, we had to really get into the mood of how do you go against someone that you're friendly with. So this was us getting into the mood. And in fact, since we're friends, I figured I would just give it up in the beginning. Liver transplantation is the most important thing to happen in the treatment of colorectal cancer liver metastases in the last 20 years, at least on April 1st. So unresectable colorectal liver metastases. I put a question mark because now with IRE on a pedicle and a remnant, high-dose ablative radiation, it really depends on where you are what your definition of unresectable is. But that's what we're going to talk about today, unresectable colorectal liver metastases. I'll talk about transplant outcomes and selection, who are these patients, best chance for long-term survival, and I'll talk about hepatic artery pump patients and their outcomes. The transplant outcomes that are published are very impressive. I don't think we're going to have a different analysis of the data. The question is, how do you interpret this in the larger field of treating unresectable patients? It's a very hot topic. It's the new Alps, or is it the mini Alps, or the micro mini Alps, or the oops Alps? That's where halfway through the case you realize you did an Alps, but you actually didn't mean to do an Alps. And that is what transplant is becoming. It's the new hot topic. So last night I was trying to get inspired, and at the bar I overheard someone say, what does it take to launch a worldwide surgical phenomenon? And I was listening because I want my career to proceed, and I thought maybe I'd learn something. You need 50 lucky Norwegians with good biology. And in fact, we know a lot about these 50 lucky Norwegians because there's as many publications as patients. We have a lot of data on these patients. So let's see what the data show us, but we have to set the stage from Norway. And this is where most of the data come from. We know that 5-year overall survival, chemo-only patients, 10%, median overall survival 2 years. Based on that and the number of lines of chemo, patients in the SECA-2 trial, which I'll show you more of the data later, would have an estimated overall survival of only 17 months without liver transplant. But it's actually very hard to find a comparison group to the transplant patients because we don't have data on these very well-selected patients, on even chemo alone. I'm going to talk about pump, but even on chemo alone, we really don't have those data. And Norway has a very unique situation. That's why Paul Dag and his colleagues were able to really launch this program where there's increased availability of organs. And in other countries, it's unclear how does this fit into even the transplant system. Will this negatively affect waiting list times, burdened by high mortality already? And then if you say, well, no, we're going to use living related, well, that opens up a whole nother line of questions that I think you have to answer. So let's look at some of the data. SECA-1, the selection. Initially, the inclusion criteria were so strict that after 11 months, there weren't any patients, so wider inclusion criteria were approved. This starts to give you an idea that we are talking about an incredibly small group of patients. ECOG 0 or 1, minimum 6 weeks of chemo, absence of extrahepatic disease. So over 5 years, with the loosened criteria, only 25 patients accrued and 21 patients transplanted. And there's even more selection than this. So if you think about a median time from primary resection, 36 months for metachronous disease, 16 months for synchronous disease, consider the outcomes for the average patient who walks into any of our clinics with unresectable colorectal liver mets who is only getting systemic chemo. Response rate only 50%. Median time to progression less than a year. Response to second-line chemo after their 6 cycles of FOLFOX, it's almost non-existent. So the patients we're talking about with SECA1 are patients who are 2 to 3 years into therapy with no obvious progression and are well enough to a transplant, not the average patient who you see. Now, looking at the outcomes, median follow-up 27 months. Almost all recurred, median time to recurrence within 6 months. But the predicted 5-year overall survival was 60%, and this started to catch people's eye that maybe transplant is a way to start bumping up this overall survival. But actually, this is just showing you about the indolent biology and selection involved in choosing these patients, not showing you the impact actually of transplant. So then we get to SECA2. Now here, the selection criteria are much stricter. This is only some of the selection criteria. The box is quite long. It's normal blood tests, no weight loss, BMI less than 30. I mean, in the US, that's a major problem. I'd love for BMI less than 30 patients. So these are patients tolerating chemo who are very healthy. No lesion greater than 10 centimeter, no extrahepatic disease, at least first-line treatment with a response of 10%, at least 1 year from colorectal diagnosis. And then the caveat that the investigators, if they wanted to for a different reason or just gestalt, you wouldn't enroll the patient. So with this tighter criteria, 15 patients accrued over 5 years, median time from diagnosis to transplant 24 months. And as you would suspect, when you really tighten the selection criteria to this long list, you get same story, smaller denominator, better patients, better biology, and the overall survival gets higher. Now let's look at these 15. These are the luckiest of the 50 lucky Norwegians. So age 59, T4, almost non-existent, almost no N2, almost no right colons. And response to chemo, extreme significant response. So max number of lesions initially 12 gets cut down to 5 by the time you get to transplant. Max size initially 4.5 centimeters down to 2.4. So these are the patients who have all these disappearing colorectal liver metastases. And again, we don't really have an idea about patients like this do just on systemic chemotherapy because this is such a good biologic group. And the outcomes show this, median follow-up of 36 months. At 4 years, there's 1 disease-free survivor, median disease-free survival of 13 months overall, 5-year disease-free survival of 35%. When you look at the low number, the less than 8 Mets, the median disease-free survival, 24 months versus 11.6 months. Now, what we're showing is more extreme selection, young, healthier patients with indolent disease who survive and remain healthy enough to receive a liver transplant. One issue is indolent disease also takes a long time to recur, so we probably don't have the final story from these patients. Any further radical alteration of the denominator, I mean, you could probably push that overall survivor number to 90%, add in another 6 selection criteria. Most patients recur, and overall survival, again, is a reflection of indolent biology. And this comes with significant complications. So SECA1, 80% complication rate, 33% major complications, and this is at a center that is top in the world. 2 retransplantations, 5 reoperations for hemorrhage, 4 arterial complications, and 8 patients with incisional hernias. SECA2, 47% major complication rate, some wound dehiscences, not as much detail, but extrapolate from SECA1. Now, what happens with what I'm afraid is going to happen in the United States or any other unregulated area? You start loosening the criteria. Oh, that lung met, well, it was 8 months ago, and it was treated, and I don't see a recurrence. Well, it was a right colon primary, but that was 13 months ago. Well, you get extended criteria for patients and donors. So the main exclusion here was BMI greater than 30 and liver mets greater than 10, and resectable pulmonary mets were allowed. And this was 10 patients, so a small group. But this is a little bit more real world. Median tumor number 20, 8 out of 10 patients with N2 disease, 5 with right colon tumors, median clinical risk score 3, and the outcomes show what you would expect. Much worse biology. Disease-free survival, 4 months. So first post-op scan, recurrence, overall survival, 18 months. And this is probably the reality of what will happen if you don't stick to this extremely strict selection criteria, which limits you to, in the end, an unbelievably small number of patients. So there was one comparison that was done between patients who were resectable with PVE and unresectable treated with transplant. This is a total of 50 patients from these 3 studies I showed you, SECA 1, 2, and the SECA 2D arm. And they were matched to 53 patients who were deemed to have resectable colorectal liver mets, but received PVE prior to resection. 18 out of the 41 patients with this data in PVE had N2 disease, and you can see that the chemo response in these was basically nothing. Same size and same number of tumors pre and post chemo. So you start to get an idea that we're talking about different biology. And the outcomes show that. 5-year overall survival, 32% from time of PVE, unknown RAS and matching criteria. A third of the patients almost didn't go after their PVE for liver resection due to insufficient growth or tumor progression. Now, tumor progression, these are the patients who will be excluded from transplant. So in reality, this is really one of the groups was intention to treat, not the other. Now, one of the findings was if you split the group up to low tumor load, less than 8 lesions, there was pretty similar outcomes. Very good outcomes for PVE and resection, 69% overall survival. 21 liver transplant patients, 72%. So the difference was really in the high tumor load. So now trying to narrow down who would you really try and select for this if you had to do a PVE and resect. Well, the high tumor load patients, and the authors felt that there was no other publications with overall survival similar to this, with on average 15 tumors. And I think that's a good segue into some pump data. This is a trial that Nancy Kemeny, who's here, and Mike D'Angelica did, looking at 5 years, 64 patients with median of 13 tumors. Over half the patients converted to resectable, median follow-up extremely long, progression-free survival a little over a year, overall survival 38 months, 5-year overall survival 36%. Now, the pump does seem to work best in chemo-naive patients, so overall survival 51%. This is a patient, 2008, 30-year-old woman, T4N1, right colon cancer, unresectable, KRAS mutant. This is one of her early scans. Didn't respond enough to FOLFOX, got a pump, converted to resectable, and this is her scan from about 2 months ago in Dr. Kemeny's clinic 14 years later. And that's some of the patients in this trial that had good biology, ended up responding very well to the pump, and were cured from this treatment. So these patients are patients that are much more like a patient who actually walks in your door, who you see. Median number of tumors, 13, prior chemo, 67%, high clinical risk score, size of the largest tumor greater than 5 centimeter, majority of patients, most had lymph node positive primaries, CEA greater than 200, 30% of the patients, disease-free interval very short, almost everybody, KRAS mutant, a third of the patients. This is a bit more real world. So this was looking at some of the long-term cures in the pump patients. So this is a landmark analysis. So at a year, if you didn't have a resection, an R0 resection, you're in the bottom line. If you did, you're in the top line. And you can start to see that the 5-year overall survival in those patients converted to resectable within a year is about 65, 66%. Now, 9 of these 64 patients, NED, after this very long follow-up. 1 complete clinical response just to HAI, a few post-resection NED, others post-resection recurred, salvaged, and at follow-up 57 to 92 months, I'd say they're cured. Now, I still haven't shown you that number that is so impressive in SECA 2, that overall survival number that seems to be driving all this interest. Now, what happens when you select the best pump patients? So this is those trial patients and patients who got pumps outside of the trial, 118 patients, all unresectable, 91% synchronous, 64% with progression in the liver on systemic chemo prior to the pump. And the way this worked to categorize into good, intermediate, or poor biology was extrahepatic disease, no, RAS, RAF, and TP53 co-alteration, yes or no. So the good group, you couldn't have a co-alteration. And if you look at the 5-year overall survival in these patients, the good group, the best selected patients, looks to be pretty similar. It's about 77, 78%. So as you whittle down these patients into the very highly selected group, the overall survival in the initially unresectable patients can be extremely high. So I would argue that there actually are data that show you can get these very high survivals in well-selected patients. Now, one of the myths about the pump is this only happens at Memorial. The data I showed you is from Memorial. Mike Lidsky and Mike D'Angelica are leading this HI consortium. This isn't just in the US. The Dutch are showing us you can do randomized trials outside of the US. There's multiple trials underway there as well. So I think it is possible to use this outside of MSK. So in conclusions, if the debate is about patients eligible for transplant, we are talking at about an unbelievably small number of patients. If we're talking about all unresectable patients, let's go down the list. So morbidity clearly would favor pump. I didn't have time to talk about it, but allows modern management of rectal cancer. Now a lot of our patients get chemo only or chemo and radiation and a pump, never have surgery on their primary tumor. That's not possible with transplant. Chance for cure in patients with great biology. That can happen with either one. But what about applicable to all unresectable patients? So it doesn't matter about your BMI, doesn't matter sidedness, chemo response, size of tumors, CEA, time. I mean, I can go on and on and on down with the list. Obviously, that favors the pump. So in conclusion, there are effective local regional strategies like a hepatic artery pump that are applicable to a much broader patient population than transplant. Thank you.
Very well, so we proceed with the debate and the argument for liver transplantation. So the next speaker is Professor Roberto Hernandez Alejandro. He's a professor of surgery. He's the chief of the Division of Transplantation and HPB Surgery at the University of Rochester, Minnesota.
That's awesome. All right. Good try, Peter. Your tacos needs a little bit of more salsa. But let's start. So this is the debate. And thank you for this invitation. This is great to be here in this hot topic. I have no disclosure, only that we were in New York City where the pump was born, and I think, not sure if the waters of the East River is what making these good outcomes that they're showing to us. But let's position our debate. This is so important. What are we talking about? These are patients who have unresectable liver metastases, that there's no evidence of extrahepatic disease, and at some moment these patients are responding to systemic chemotherapy. The metrics should be survival, progression and disease-free survival, and quality of life. These are the patients that we are talking about. This paper in 2006, look at the difference between systemic chemotherapy and pump. Only 4 months of difference of median survival. And if you look closely to this paper, 66% of the arm of the hepatic artery infusion pump are the ones who went for colon resection, compared to 38% of the systemic chemotherapy. Whether maybe the resection is mediating the outcomes, probably. And if you look at the graph, by the way, no survivals at 5 years, okay? No survivals at 5 years. That's not impressive to me. Hit number 1. Let's go to this meta-analysis as well. 15 years ago, this paper clearly shows that it was declared the end of the era of hepatic artery infusion. It should not be used as a first-line chemotherapy in clinical or investigative settings. And remember, at those times, we didn't have the modern chemotherapy. We didn't have FOLFIRI, we didn't have FOLFOX. It was everything based on FIU. So probably the outcomes with this systemic chemotherapy could be even better. There was no more meta-analysis whether this was advanced. This strongly underscored the lack of evidence of hepatic artery infusion for the treatment of unresectable colorectal liver metastases. Bang. Let's go to this prospective phase 2 trial. So now, pump needs systemic chemotherapy, not only the pump. Now, okay, they use 5 years. Previously, they reported that with the similar patients, 3 years, no control group in this trial, no control group. This was really a case series that they were reporting. It's prospective, not retrospective, that's good. But the variables were very similar to a retrospective study. And interesting, the progression-free survival that Peter shows in the previous paper and in his slide was just 13 months of progression-free survival. I think hepatic artery infusion and chemo has not been shown to be better than chemotherapy alone. And yet, 2 days ago, when they were presenting the group from Duke, I'm very glad to see that there's a trial coming about 2 patients going to the pump blindly and 1 patient going to the systemic chemotherapy because they really need to prove that this works. So for those ones who doesn't know what is the pump, this is the pump. Imagine it's a hockey puck. in front of your muscles, below your skin. And when you have to go through the airport, then you have to go to another route because you cannot, it's gonna be beeping everywhere. And this is not comfortable, and it can flip, right? And there are complications, vascular complications, more often than I think what I thought. And thrombosis and dislocations, they call it, and those things. And this patient, for example, look at this dissection in one of the arrows. You can see dissection of the artery. They need to try to fix this one, then start bleeding. Patient is bleeding badly. They need to put a lot of coils there. Now the patient has hepatic artery, no flow. Now the patient is referred for transplantation because his bile ducts are gonna be destroyed. So those are some of the vascular complications of many other ones that we have. Oops. Biliary toxicity, according to the literature, between 6 to 15%. And these patients, you cannot put stents because these patients have biliary complications all over in the liver. It's like, those ones who do DCDs that have ischemic cholangiopathy all over the place. They need PTCs. They're like Christmas trees hanging with the ornaments at the side. So this is pretty impressive to see these patients. Look at this one. Not one, not two, not three, four. 4 PTCs hanging there. And look at those incisions. That's interesting. However, this patient was, you don't have cancer anymore. Your liver is burned out. However, your bile ducts fail, your liver failed, but you don't have cancer anymore. This patient came to transplantation. Believe it or not, this is a liver. It's a liver after the pump. So pathology comes back, 4 spots with cancer. The patient was told there's no cancer. There were cancers still there. Burnout cancer, I would say burnout liver and bile ducts. In this study of more than 3,000 patients, clearly showing thrombosis, flips of like dislocations and those things, 34% surgical complications, 36% radiological complications. Many members of this paper from Memorial, 464 patients, 84% of the patients here have concurrent surgery with hepatic artery pump. Let's talk about, if we're talking about pump, you need to resect the patient, right? To be able to perhaps cure the patient or improve it. So we're talking about that in this paper, death or serious mortality would be in this population of patients that requires major liver resection or major liver resection and colorectal surgery. So the death and serious morbidity will be between 30 and 40%. So I think this is pretty impressive. And I have a question for all the group from the pump. Decades of clinical outcomes. Where is the level 1 evidence of the hepatic artery infusion? I don't see it. Not sure if you know something more. Liver transplantation, they said that we have a lot of complications. Yes, in the MELD scores of 35, 38, like more than 20s. But we're talking about this population of patients. They have a MELD score of single digits. They have a MELD score of 6, 7, 8. And when you do living donor liver transplantations, those are the complications. And deceased donors liver transplant with MELD score below 20, pretty acceptable complications rate. And just to support this, look at this study of more than 80,000 patients, 5-year survival of 82% overall in liver transplantations, and when you in living donor, and in deceased donor 77%. And we're including patients that went for living donor with MELD scores of 19, 29. So if we look at those ones who are single digits or below 10, these patients, probably that graph of 82% will come to, 87, 86%. We have been accused in liver transplantation that we are super selective, and we hear it today as well in previous debates as well. Yes, we have to be careful. We have to select the patient because we want to be sure that the patients do well. We're not going to be just doing everything for everybody. No, and living donor liver transplantation, we have to follow double equipoise. We have to justify putting the life at risk of a donor when we're going to have a good outcome in the recipient, and that's what we have to do. Risk of mortality of a donor is just 1 in 1,000. It's important to have, if you have 1, it's a disaster, but we need to be very cautious. And wait a moment. Living donor liver transplantation is a standard of care in HCC. Nobody complains about doing liver donor liver transplantation in HCC. And look at these patients. These are donors who the outcomes of colorectal metastasis in well-selected patients is above liver transplantation for HCC within and outside Milan criteria. So that is the reason that is something that is acceptable, and we're not experimenting here, and it has been proved. Transplant is not a morbid operation, and living donor is safe and acceptable option in selected patients for transplant oncology. This is what shake the tree, and very impressive outcomes. The group from Norway came with this Oslo score, and we're following it, and it's quite impressive to see the good outcomes in well-selected patients. And those patients who have recurrence, a lot of them are resectable, and they go to no evidence of disease. And we can use the Oslo score, and we can use the Memorial Risk Score. When you go for 0-2, you can have pretty similar outcomes of these patients. Thank you, Paul Dack, for sharing this with me. There's this study that hopefully gets accepted. This is SICA-1. Those patients with Oslo score 0-1, the 5 and 10 years overall survival are 75 to 50%. Are we curing patients? Yes. 10 years, I know that Mike DeAngelica loves 10 years survival, and here it is, between 25 to 30%. Long recurrence is very common, however, is treated with curative intent. And recurrence after liver transplantation for colorectal metastasis is not an accurate surrogate of survival when compared to recurrence after liver resection. These patients' recurrence is very different. This paper that our group published and showing clearly that liver recurrence after transplantation around 3%, very low. Compared to liver resection, the recurrence is much, much higher. And if we add the patients who have multiple, because some of them include liver, it will be more higher. In the other side, you can see that those patients who recur in the lungs, they have an impressive overall survival. If they have in the liver, outcomes are not going to be good, but the percentage is extremely low. So this is a very different way of recurrence. This paper is impressed, accepted. 70 patients from the group of Norway, they're alive and diseased. You can see dark, alive, disease in pink. The important is this line. These are patients that they are no recurrence and they are surviving, so these patients are potentially cured. Those are the patients, and several of them in the top are more than 5 years. And if we look at this area here, all of these patients have more than 7 years to be alive. Some of them already died, but they have all of those, they have recurrence. So this is clearly showing that recurrence is different, that is not associated to death in transplantation compared to liver resection, that once a patient recurs, the outcome is going to be much, much poorer. Mike, 2 or 3 weeks ago, he said, you are super selecting patients and transplant outcomes could be obtained with prolonged chemotherapy. Are you sure? I don't think we're over-selecting patients. This is selection. This is what we're doing. These are the patients that we are transplanting after they get treated with systemic chemotherapy and doing allele selection. Let's talk about over-selection of patients. Let's talk about these. So if you don't drive this car and park in the parking lot of Memorial like this, if you're not wearing the Prada shoes and the Armani suit, and you don't have an insurance to be able to cover that room, you're not allowed to go to Memorial to the best cancer care analysis. Remember, these transplant patients, they receive more than 1 year of systemic chemotherapy, right? There is hepatotoxicity. Very common that these patients won't be able to tolerate more than 6 months of FOLFOX or FOLFOXIRI. You know, they have a lot of side effects. So these patients are in second and third line chemotherapies a lot of the times. And look at the progression-free survival in these high impact factor journals in colorectal liver metastasis when they are in second line. Progression-free survival 7 months. Third line chemotherapy, progression-free survival 2 months. And patients with a pump require systemic chemotherapy, okay? Important. This slide, I think Mike used it several times. Major liver resection in heavily pretreated patients, we need to be cautious. Look at those outcomes. Major resections have 40% major morbidity, 10% mortality, disease-free survival at 5 years of 13%, and 5 years overall survival of 40%. Those patients who receive 12 cycles, transplant, they have like 24 at least cycles or more. Those who have 12 cycles, recurrence is universal, 55% major morbidity. I think liver resection in these patients have a high morbidity and mortality. Giving more chemotherapy is not going to make things better. It's going to make things worse in this patient. Boom. Someone say Norway is not the rest of the world. I would say MSK is not the center of the universe. This is a paper from Cleveland Clinic, from Rochester, and Toronto. And it was just 2 days ago published. And it's showing clearly, validating very similar data that is coming from Norway with very acceptable overall survivals and recurrence-free survival. We don't have a long-term follow-up, but this is the way that we start, doing the things in the correct way. Bang. All right, this patient, multiple liver metastases, probably if my friend from Brazil is here, he will say this is resectable, right? The patient received chemotherapy, and the patient was offered a pump. The patient decided to come with us for a transplant because, and there was a lot of concerns because the patient has a very good response, and you can do a right posterior and maybe an ablation in that left side. Guess what happened? Look at that. I'm glad that the patient had a transplant. This is the power of the total hepatectomy. Left side of liver full of metastases. All right, look at this patient. I don't think you can do a resection with this one. I don't know if Eduardo is here. Maybe he will find a way of doing it. But the patient received had a very good response. Why you're changing your strategy if you're winning the game with systemic chemotherapy and the patient is doing very well? Why are you going to change to the pump? If the patient is progressing, okay, use a pump. But if not progressing, continue with chemo, and maybe the patient can go for transplant. And then the patient received a transplant and multiple liver metastases still there, and with a gross pathology showing that there's cancer there. Our lab fellow, Mariana Chavez, is working in this paper. 60% of the patients, these are 14 patients, with complete radiographic response, including MRI, CT scan, and PET scan, demonstrated residual gross disease in explant pathology. This is very important. This is why these patients start recurring in the recovery room when you do liver resections on them. I know someone wants to throw the towel. So this is our data in Rochester. We're doing things through a trial, and this is our outcome of 9 patients that we have transplanted with very good outcomes so far. Some of them are very short follow-up, but things are going in the right direction. So with all the things that I have said, this editorial was published just 2 weeks ago. And it's talking about patients who receive chemotherapy and what we're doing for them, going and on and on and on for these patients. Time spent at the beach is time well spent. Time spent at the hospital is time not well spent. You tell me where you want to be. You want to be in the beach after your liver transplant enjoying life? Or you want to be at the fusion center every second to third week? Think about it. Why we're here? We know, all of you, why we're here. The reason that we're here is because they think that we're going to take their business out. No, we're not going to take I think there's room for everybody here. There's a new kid on the block, and that's transplantation. Look at this, just 200 papers in decades, and around 1,500 in transplantation for colorectal liver metastases. I think there's room for both, and we can be more clear with indication. We stop here. The only thing that I'm asking is, if there's a patient with unresectable disease who's responding to systemic chemotherapy, no evidence of extrahepatic disease, the patient goes for a pump, ask a second opinion. The transplant surgeon should see this patient and maybe give the opportunity to the patient to decide where they want to go. That's what we do. We ask, when they come with us, we offer them second, third, fourth opinions. The patient should be happy, and all the options should be explored in these patients. When they go for the pump, and then they go for transplant, it could be a disaster operation. And with this, I think at the end we can be friends, and everybody can work in the sandbox. Thank you.
Please come on. Thank you. It was very well done. Was very well done. Congratulations to both of you. You are fascinating and great stuff. Actually, it was very interesting because you both spoke about the other technique. So you spent 3/4 of your presentation talking about transplant, and you spent 3/4 of your presentation talking about Asia.
He's expert in transplant.
So but it's fine. This is exactly the beauty of this debate, and I like and I congratulate both of you. I think we should now try to debate with you guys. I have just a few questions for me to knowledge, and I'm going to ask you. Peter, about 2 things. Number one, when you do HAI, are you also doing a systemic chemo on the same patient? And number 2, what do you see about doing a HAI on patients that are candidates for liver transplant?
So yes, HII is almost always combined with systemic chemotherapy. In the last 15 years, that's what all the studies have gone with. And the recurrences, especially in the lungs, is less when you combine with systemic chemo. So usually both. Lower dose FOLFIRI is usually what's used. And to be honest, your second question is a little confusing to me because I'm still waiting for the transplant eligible patient to walk through my door regularly. I mean, we are talking, if we extrapolate population base, there's 5.5 million people in Norway. They were accruing 4 or 5 patients a year to SECA2. 330 million or so in the US. We're talking about 300 patients in the United States of America. So we are talking about an incredibly small group of patients, not the average patient who walks in the door. So if a donor asks, is there any other way that this procedure can happen and the patient can be cured without me giving a piece of the liver? The answer should be yes. I just showed data that similar survival in really well-selected patients getting a pump. So no, I actually am a bit confused by the heightened activity around liver transplantation, to be honest, because I think it is for such a small group of patients, and I think there are alternatives. You mentioned HCC, which I think it's great to have that come up. There isn't an alternative like transplant. So yes, it makes sense to focus on transplant. But in colorectal, there is an alternative, which has much less morbidity, all the things that I showed.
But do you agree that liver transplant is eventually the ultimate R0 resection?
There is no way to resect more liver than a liver transplantation.
Right.
I
Okay.
agree with that.
That's what I want to hear about it. What do you think? Combining, the problem with liver transplant, and I'm glad that Paul Doug is here. The problem with liver transplant with colorectal liver mets, it's unfortunately the recurrence of disease in the lung. I mean, it's you can treat it, you can control it, but not always they can go to the beach if they have a lung metastasis. Yeah. So, unfortunately, I had some experience with patients after liver transplant with metastatic lung tumor. And, sometimes you can resect it, but not all the time. Then you have to go again on systemic chemo and worry about radiotherapy. So what's the strategy you can figure out to see if there is a strategy to avoid or decrease the chance of recurrence?
All right. So thank you for your question, Antonio. And definitely recurrence, it's quite common in patients with liver transplant. If you go and do a retrospective study on those patients who have recurrence, perhaps a large population, a group of these patients, they already have some nodules there, probably. Not necessarily are patients who are having recurrence, perhaps there's residual disease there, and then it starts growing. What is interesting is that immunosuppression has been showing that the growth of the tumor compared to patients without immunosuppression and those ones with immunosuppression, the rate of growth is exactly the same. So immunosuppression is not affecting the growth of lung metastases. Interestingly, lung metastases can be resected, and they not necessarily require chemotherapy when you wait for them to grow 1 centimeter or 8 millimeters, and then your thoracic surgeons go, patient is out of the hospital in a couple of days, and they do BATs and they remove these. You confirm if there's 2 or 3. If there are multiple, well, we're talking about other disease, and then probably you didn't do a good selection of patients at that moment, and the patient will need to go for chemotherapy. Chemotherapy and transplantation is not a terrible thing that happened to this patient. And it has been, I know there's some trials in Italy, I know in France they're doing also as well with these patients, but definitely this population of patients with recurrence, they go to no evidence of disease, and they have a phenomenal and amazing overall survival. Compare when we do a liver resection and there is recurrence. Recurrence is more associated in liver resection with a worse outcome compared to liver transplantation. But the importance of here overall is to select the patient. And yes, it's a small population of patients, much more smaller, but that's what we have to do. We have to be selective to be able to offer them a deceased donor, because they're going to take the space for another patient who has cirrhosis, or put the life at risk of a live donor. Therefore, we need to give a good warranty that that potential recipient is going to do well.
Correct.
Okay, so clearly this is selection is the key here. We have a comment from Paul Dyke.
That's
Please.
one of the 50
Oh, yeah.
healthy guys.
I feel a need to correct some misconceptions because you are giving the picture that we are only able to accrue about 2 or 3 patients a year from a population of 5 million people. And that's a total misunderstanding and not giving a correct picture of the real case. So I have been along the complete journey and know exactly what happens. So when you stand up in a meeting in 2006 that suggests that you are going to start doing transplants like this, you're not creating a lot of friends. And you're not accruing a lot of patients. And the CECA1 population is not in any way particularly selected. And the 10-year survival in the low-risk portion is 50% observed survival, not estimated. The other thing is that transplant oncology is a selective treatment for one specific reason, and that's our obligation to make sure that we utilize grafts in a responsible manner. For sure, most of the patients that we transplant would probably do better than with the alternative. That's my personal experience, at least. So I think that this is a big misconception, the big selection thing. The third is we have done 2 separate studies on the health economics of things. And transplantation is much cheaper in terms of cost of quality years gained than any chemotherapy. Thank you.
Okay, hold on. You brought a ringer in here. All right. Now that's just not fair. Well, Paul Dyke, I have endless respect to be a pioneer in a field. Most people, including me in this room, will never have that title put on us. However, what I would say is that doesn't change anything about what I said. We are talking about a massively selected group of patients, which realistically is such a small group that how do you extrapolate to all patients with unresectable colorectal? You can't. So then you look at this well-selected group and you say, is there anything else that can be offered to these patients? And the pump data shows in very well-selected patients, you can have pretty similar outcomes with a very different treatment. So there's a treatment you can provide to everybody. The indication is have people come in with unresectable colorectal liver metastasis. That's it. That's the only indication to have a pump. Nothing else. The list is not this long. So in many ways, it's not even a debate. I don't know how to even compare them because one is offered to everybody, and the best biology patients, they'll do really well.
Okay, another question from the floor.
Mike Kavner, University of Kentucky. Thank you guys for just an incredible debate. This is a real-world question, and patients are asking this, and I share patients with some of you. And can you both comment on the intersection of each other's therapies? Because in the reality right now, we're in 2 different silos. But these things intersect. I have 30 patients I put pumps in, and some of these patients are going to get to the end of their ability to receive pump therapy. And what happens to those patients? Some of those patients may become eligible for a liver transplant, or the few patients that get biliary sclerosis. And on the flip side, Dr. Hernandez, what patients do you see might be best to start with a pump? Or do you see any of them?
So I'm not an expert in the pump, but I can tell you regarding how they interact. The problem of when these patients, I know the pump works and it really controls the disease in the liver pretty good. The problem when these patients come back for transplant later on, it is extremely complex because the pump is creating a lot of reaction and inflammation, chronic inflammation in the porta hepatis. Plus the dissections that you guys do of all the lymph nodes around. The bile ducts are toast, you know that. And it makes very complex. And if you're planning to do a live donor, you need to have a pristine artery. And you're gonna be in big trouble here. And if you use a conduit, there's gonna be significant discrepancy of your iliac artery with your right hepatic artery of your donor. And it's gonna be, your rate of complications is gonna be much higher. If we could have cadaveric donors, which is not an indicate. It's difficult to get it. I know that probably Shimul is here and he's going to say that he can do a lot of the cadaveric donors. I think it depends where you live and what is your proposed outcome, but it will be much better. Hopefully in the future, we can offer to this patient exemption points and get the transplantation for them with deceased donors. But the pump going for transplant after the pump is a very risky operation and with way more higher comorbidities and mortality. That's what I can comment.
I'm sorry, I see David Geller here. We have to stop, right? We're late. Okay, I'm sorry. I have to close. We finish with the clip.
Can you please take your seats? We're going to get started with the next session.
There's no pointer. Anyway, I cannot point over there.
Okay, let's get started. Please take your seats. Our next session is IHPBA meets ILS. This is a double society with both IHPBA and ILS is the International Laparoscopic Liver Society. I'm the co-moderator, David Geller, from the University of Pittsburgh. Unfortunately, the other co-moderator, Nick O'Rourke from Australia, Brisbane, was unable to attend, so he sends his regards and hopefully he'll be logging on remotely. And also because of COVID quarantine, two of our speakers last minute, one from a medical health issue and one for COVID from Italy and the Philippines could not attend. So hopefully we'll have their lectures virtually. And we have a very good session focusing on the latest advances in MIS major hepatectomy, and it's a privilege to introduce our first speaker, Dr. Daniel Cherki from Paris, France. He was a past founding president of ILS, and his talk is entitled Laparoscopic Right Hemihepatectomy. We'll have the video and talk presentations, and we'll have a discussion section for the last 15 minutes.
Well, thank you, David. Hello, everyone. So the title of my talk is Standardized Pure Laparoscopic Right Hepatectomy. I have no disclosures, and I think that right hepatectomy is a very good example of a well-defined advanced procedure which can be standardized. And no matter which order you will do it, you will need to deal with the hilum, the middle hepatic vein, the transection, the right hepatic vein, mobilization, and IVC. And also you have to deal with the long transection line. It's a long journey through the liver. So the methods for minimally invasive right hepatectomy, the main ones nowadays are the pure laparoscopic approach, which is currently still the most employed technique. It is genuinely challenged by the robotic-assisted operation with definitely growing numbers. People are happy with it. We have, however, limited data at the moment on the outcomes. The previous methods, including hand-assisted and laparoscopic assisted, are less employed nowadays. So I'm going to focus today on pure laparoscopic. I'm going to tell you about my personal experience, and then we'll look to the technique with a few video clips. So my personal experience since 2013, when I joined Paul Broos Hospital, is here, and currently I do, over that period, my laparoscopic rate was 52% of all my liver resections. In terms of hepatectomies, if we look at right hepatectomy, 50% are done laparoscopically in my experience. The results of Paul Broos over the past 8 years, during this period, was 67 cases, a conversion rate of 9%, 1 for bile duct injury, patient of mine, and I will tell you, and 5 insufficient exposure, no transfusion, no mortality, and 2 grade 3 complications, including 2 bile leaks and 1 pneumothorax. Now let's talk about the standardized technique. I found, this is my previous experience from my previous hospital that we published in 2009, and it was the early days, and right hepatectomy was a major undertaking in these days, and actually I started doing laparoscopic right hepatectomy in 1999. And in these days, my standard technique to right hepatectomy was the anterior approach, which is right liver mobilization after transection has been completed. And this is also what Olivier Soubrane has published, and we should acknowledge this important paper that I encourage you to read if you haven't, where it was the first attempt at standardizing right hepatectomy. Number 1, hilar dissection. Number 2, transection. Number 3, liver mobilization and extraction. So I'm going to show you my current technique of laparoscopic right hepatectomy, which is totally standardized. So the setting that we have is, and this may be debated later, is we use a 4K 15-screen, large 15-inch screen, 30-degree laparoscope, ICG on a separate tower. We use energy device. The current one we use is Thunderbeat. Any energy device will work. It's what's better. It depends on your preference, but we need one. One thing that I cannot live without is the CUSA, and the CUSA, I will show you the transection technique that we use, is at the center of our techniques for all liver resection, for all liver transections. Linear staplers we use only for undissected vessels, not for the parenchyma. And all these linear staplers work very well, and you can use any one you want. Patient position, we use a minimal decubitus to the left to help liver mobilization, and this is where we put our port. Our ports are put along a long subcostal incision, and actually what's important for the ports is that the camera is facing the transection line, and the transection line is done in the middle, the transection line is in the mid-axillary portion. So we have 1 camera port, 2 working ports, and 2 exposure ports, 5 millimeters. I'm sorry, I just want to mention at this stage that I moved from mobilization of the liver at the end of the operation, like Olivier Soubrane was recommending, and I was recommending before, to mobilizing it at the beginning, because number 1, we have learned we're more familiar with liver mobilization up front at the moment. And number 2, at the end of the operation, I found it difficult to mobilize the liver, which is totally detached from the rest. So basically, this is the standardized mobilization. We go from above, we go as far as we can to the right. This is obviously a double speed, right? Then we go to the side, and from the side, we join the dissection that we have done from above. And then we go below the liver. So for simple right hepatectomy for tumor, I stop the mobilization at this stage. For living donors, for example, we need to mobilize completely and clean the vena cava. So here, for example, here's an inferior right hepatic vein which is divided. Then we can get access to the IVC ligament, which is also divided with the stapler. And this gives access to the right hepatic vein. And then we can encircle the right hepatic vein and place a tape around it. The tape can be used for the hanging maneuver eventually. So then we move to the the hilar dissection. We divide the cystic duct and the cystic artery. We keep the gallbladder attached and pushed above as a handle for exposure. We lift the cystic duct, and this gives access to the right hepatic artery. I show the bile duct here because this is one time that I had an injury of the bile duct that led me to conversion to make sure that I would repair it well. It's because obviously the right hepatic artery in the regular anatomy lies behind the bile duct, and this is something we have to keep in mind. So once the artery has been taped, you can clip and divide the artery. The portal vein, another point that I want to stress is that you must identify the main portal trunk and the left portal vein and the portal vein bifurcation before you divide, because one day you will divide the portal vein if you don't do this. So make sure that you see both of them, and then you can apply a stapler or clips. I prefer to use a stapler on the right portal vein. And when you do a dissection like this, it's usually easy to place this stapler. And this gives you an ischemic delineation of your right hepatectomy plane. But obviously nowadays we use the ICG. You inject the ICG after the right portal pedicle has been divided. And this gives you the surface ischemic margin. It's a negative, it's a counter staining because we stain the remaining part which is still vascularized, while the right part is not vascularized. We use this also obviously for living donors, but it shows you also inside the liver, the green margin between two sides of the liver. Two points I want to stress for transection, which is the next step, is number one, you see the low CVP on the right side because you can see this pulsating IVC, and this is what the anesthesiologist do with low CVP anesthesia. I rather call it low fluid anesthesia rather than low CVP anesthesia. Actually, we don't even measure the CVP, but our anesthesiologists are making a point of giving very little fluid to these patients before the transection, and they catch up after the operation. And the second thing is that we have liberal use of inflow occlusion. We can start without inflow occlusion, and then at any time when it's even oozing, I have no problem, and we have no problem just applying an inflow occlusion. Nowadays we use extracorporeal clamping, which is very easy to put in place. So this is the transection technique. This is unclamped at this time, and you can see and so we use, for the periphery, we use the energy device, and then we use the CUSA inside. We use the CUSA with monopolar cautery at the tip. You have to be careful with that. You have to know how to use it. This is middle hepatic vein. This is V5. And so in the right plane, because the plane of right hepatectomy is going along the middle hepatic vein. It's a bloodless field. And then we can, usually after that stage, we apply the Pringle maneuver. For the bile duct, we open segment 1, we go above, and when we see the hilar plate, we go above the hilar plate, including the bile duct. We use ICG, as you can see in the lower end corner, and we staple safely without any problems with the remnant bile duct. Once you have cut the bile duct, the liver opens like a book, and this is where the caudal view allows you to finish the transection line, the posterior wall of the right liver, just in front of the vena cava. And here you continue, you see the middle hepatic vein. And there, this is a V8. V8 may be a very big vein, and this is a dangerous vein that if you can get into trouble with this vein. And you can go either for bleeding or gas embolus. So what you want to do is identify it, clip it, or staple it, and divide it. Once you've done this, you get access to the right hepatic vein from the front. And this is the right hepatic vein. This is the typical view during the anterior approach. And then we continue here with the right hepatic vein division and complete the operation. Put a tape around the right hepatic vein, staple the right hepatic vein. And then what's left in the back is the IVC ligament, because we have just done a minimal mobilization here, so the IVC ligament is now also stapled from the front, and you can see the IVC here, which is safely dissected out of the resection line. And then, because we have mobilized most of the liver, it's very easy to finish the operation by just mobilizing the remnant coronary ligament, and then the liver is free to be extracted. Completing the hemostasis here with bipolar, you can see the middle hepatic vein in the middle. We'll reattach the falciform ligament to avoid torsion of the liver. And I believe this is, we all know that this is very important to avoid torsion Budd-Chiari syndrome because of the space of the right liver which has been removed. So we always do a CT scan at day 3 or 5, depending on when the patient goes out of the hospital. We do this before removing the drain. You can see the drain. And because we don't want to send the patient home with a potential complication or collection. If there's a collection, we decide whether we want to puncture it or not, but we do a CT scan before discharging the patient. And this can be debated as well. Finally, my take-home messages are that pure laparoscopic right hepatectomy should be standardized and can be standardized. The important messages are optimal trocar placement, standardized right lobe mobilization, high layer dissection of hepatic artery and portal vein, anatomic delineation, low CVP anesthesia, liberal use of Pringle maneuver, precise Cousette transection, transparenchymal bile duct division, careful middle hepatic vein dissection, right hepatic vein and hepatocaval ligament with stapler, and reattach the remnant right lobe. Thank you for your attention.
Thank you for that excellent technique. Our next speaker will be Dr. Go Wakabayashi from Agio Central Hospital in Japan. He's the immediate past president of ILS, and he'll be speaking on ICG-guided anatomic liver resection. Go. Can you reset the timer to 12 minutes, please, to the AV team? 12 minutes.
Thank you very much.
Thank you.
I'm going to spend the next 10 minutes probably, and I chose the wrong video because it's a segmentectomy, so not major hepatectomy, but ICG-guided anatomic liver resection. I have no conflict of interest. Some video has contained some voice Brisbane terminology. Is nice, of course, but it's 20 years old, so we need to update. First order division, second order division, and third order division, but we need to define the segment. And we need to define more precisely how to perform a segmentectomy. This is a third order division. And also, the original Brisbane terminology includes segment 9. We abandoned this segment 9 after the consensus meeting, which took place last year, precision anatomy consensus meeting. And of course, Quino's, this is Quino's grave, and Quino defined the segment 1 to 8. And that's still, we refer Quino segment, but this is Professor Makuchi's paper, and he found the Quino segment area cannot be identified because the area, can I go back? Sorry. It's a video, so, okay, I skip. So what we did in the precision anatomy, minimally invasive HPV surgery consensus meeting, and we incorporate Takasaki's idea, Grisoni approach, conunit. That's all about. So we published this Tokyo 2020 terminology of liver anatomy, updates of Brisbane 2000 system. This is open access, so you can find it, this with DOI number, published in January issue of JHPBS. So what is anatomic liver resection? Definition number 1, anatomic liver resection is defined as a complete removal of the liver parenchyma confined within the responsible portal territory. So portal territory is important. Definition 2, anatomic segmentectomy is defined as the complete removal of a territory or territories of a third-order portal venous branches of a quinose segment. So this is a good example, segment 5 tumor. So we need to perform segment 5 segmentectomy, but segment 5 has a 3 cone unit, green, yellow, red. So we have to take all these 3 cone units. This is a supplemental video which attached to the main paper. Also, you can watch it with a narration. So we perform a segment 5 monosegmentectomy, colorectal mets. This patient has another colorectal mets in the segment 8 and 2. Those 2 colorectal liver mets are removed from a partial resection, but segment 5 colorectal liver mets are located a little bit deeper inside this area. So we decided to perform a monosegmentectomy 5, taking 3 Grissom pedicle goes to 5. So green, yellow, and red. So we gradually realized that those, also we have to refer this area to the shape of the area to be resected. And we gradually recognize a segment has not 1 Grissom pedicle, but also 2 or 3 or 4 more segment. The segment 8 is the largest. So now we're taking anterior trunk from the Grissom approach from extrahepatic Grissom approach. Then we open up a Grissonian parenchyma to find the first G5. We know we have 3 G5s. So G5, once we find it, we just clipped and divide it. Then you go deeper, but decided to break parenchyma a little bit more on the country line. So I wanted to see where is the country line. After clamping anterior trunk, we ask anesthesiologist to inject ICG, IV, 0.5 milligram per body. So diluted ICG is the key to see a differentiation of intersegmental plane. So now we open up a country line, then we go deeper, then we found another G5. This must be the second one in yellow or green. Then it's clipped and divided. Then finally, we taped the last G5. This is the last G5. I think it's a cranial side of G5, so it's green, whatever. Then I placed a clamp. Then again, asked anesthesiologist to give an IV injection of ICG, the same dose after the clamp. Then we see the border between 5 and 8. So this is very important. Negative staining, you need to have a Grissom approach like this, but then you see the border between the segment, like 5 and 8 and 6 and 7. There's no landmark outside. You have to have this type of a surgery if you want to have an anatomic monosegmentectomy. Then we try to follow the intersectional segmental plane. I think a CUSA is good to see, but you might be noticing my movement of a CUSA is a cranial dorsal movement. So CUSA has to be, moved from medial to lateral and the dorsal to ventral. Then that means the cranial to the caudal. So hepatic vein runs from the cranial side to the caudal side. If you follow those direction, you can't damage hepatic vein by using a CUSA. So you're just following the plane. It's stained green and not green. Then you have a nice, precise anatomic resection. Monosegmentectomy 5 is now completed. So definition 3, anatomical subsegmentectomy is defined as a removal of the liver parenchyma within the portal territory of less than a quinose segment. These are also defined as a cone units, and the areas can be intraoperatively assessed by using ischemic demarcation, ICG staining, or both. So this is another example. The hepatocellular carcinoma locates in 6 and 7, but you can preserve the ventral side of a segment 6 area. So we decided to perform a segment 7 monosegmentectomy plus caudate plus process plus one subsegmentectomy of segment 6, dorsal side of segment 6. This is also another video attached to the paper. So with narration, you can visit the Wiley online site to download this video. Or maybe you can visit IL's website, you can download it. So Jehones witness patient, solitary hepatocellular carcinoma, and ICG retention rate was 13%, so we can remove probably 20% of the liver, more than 20% of the liver. So caudate process, segment 7 yellow, segment 6 subsegment in the green. So this preoperative simulation gives you a whole idea about the surgery. Professor Kokudo gave his lecture today. He said he named it a virtual hepatectomy. And Pringle is our routine. So once you ligate inflow, then you take G1. This is Grison Pedigree goes to caudate process. I think this is a key to find the G7. Once you divide the G1, G7 is sitting just behind this area. So you just, segment 7, root of segment G7 is here. So even for G7, you can approach from the hilar plate. This is a G6, but this patient, the G6, has 2 branches, ventral side and the dorsal side. So I'm going to take only a dorsal side of a G7, a G6. So now the border between caudate process and G6 is now divided. Then the root of G7 is visualized. I'm sorry, this is a dorsal side of a G6, subsegment of G6, segment 6. Then the demarcation line is visualized, and the short hepatic veins is divided, and the inferior right is also divided. Then again, I ask anesthesiologist to give IV injection of 0.5 milligram per body ICG. The right liver is fully mobilized. This is hepatoligament, vena cava ligament. Then ICG starts shining. You might notice the camera is different, so you have to think about the sensitivity of the camera. But those 2 cameras employ overlay technology, so overlay is better for sure. And now the border between the segment 6 dorsal, segment 6 ventral. Then again, same thing, you just follow the intersegmental plane, stained in green, not in green. That was B7. So caudate process is almost removed, and G6 subsegment is also removed. You're just following the. You can even use a Caesar. You can even use Caesar to sharp dissection to follow the intersectional segmental plane like this. This is the border between the ventral segment 6 subsegment and the dorsal subsegment 6, and the border between segment 8 and 7. So a right hepatic vein is fully visualized like this way, and vena cava is also pulsating nicely. So good thing is a little bit too much time but the good thing is exactly same volume as we calculated the preoperative, 143 grams. Segment 7 monosegmentectomy plus segment 6 subsegmentectomy with caudate process. So ICG-guided visualization plane from the systematic review. My son Tiger conducted a nice systematic review, just published in last month. Negative staining seems to provide a bit higher demarcation, better scores in terms of general quality of a fluorescence image, and the comfort, satisfaction of the surgeon during the technique in robotic-assisted liver resection. Positive staining requires expertise for manipulating IOUS and the needle puncture, especially in minimally invasive settings. So probably negative staining is better than positive staining in the minimally invasive surgery, but Grisona approach is mandatory for negative staining. You have to know how to perform Grisona approach. This definition for, okay, let's move ahead. So we define the segment 9 is abundant. We define anatomy segment Y. 1 is classified as 3 parts: the Spiegel lobe, the parkable portion, and the cowled process proposed by a Japanese pathologist. So Spiegel has a 3 subsegment. So we published all this report. Please visit this. And thank you very much for your kind attention.
Thank you for those excellent videos. For those standing in the back and the side, we have plenty of seats in the front here, so please, it's more comfortable. Come sit down. You can still see the videos. Our next speaker is Dr. Marcel Machado from Sao Paulo, Brazil, and he'll be talking about laparoscopic and robotic ALPS. Can you guys reset the timer, please, to 12 minutes? Thank you.
Okay, first of all, thanks for the organization for inviting me to talk about this interesting topic, a minimally invasive ALPS procedure. So, nothing to disclose. After the first report of ALPS, we've seen that there was a need for a better selection of patients for better results. And the better cases were in patients less than 60 years old and for colorectal metastasis. However, the ALPS continuously improved along the time because of better patient selection, but also because of a technical refinement. And one of the technical refinement I would like to point out today is the minimally invasive ALPS. We published in Annals of Surgery in 2012 one of the first total laparoscopy ALPS procedure. And this is what we've done at that time. And then we select some cases to do this. This is the way we do by laparoscopy with 5 trokers as displayed in this figure. This is a small video showing a multiple metastasis where the future liver remnant was only 15%. So we decided to do an ALPS operation, and with cleaning of the left lateral segment. As you can see here, there are some small metastases on the left lobe. This is after, of course, after chemotherapy, systemic chemotherapy, neoadjuvant, with a good response. So this is a resection of those small metastases on the left lobe. At the time we were using, this was through bipolar forceps. This is another metastasis. And after that, we're going to dissect the right portal vein for ligature, and we be sure that there is no anatomic variation for anterior and posterior part of the right portal vein. Then we place 2 ligatures, make sure that the left portal vein is, of course, in them, we spare. Then we complete the operation by doing liver partition at the level of a falciform ligament between the segments 3 and 4. This is the final view of the first stage of the laparoscopy. There was a huge increase of the future liver remnant. This is the CT scan. We operate this patient after 4 weeks, and we use the same trocar incisions. This is the view after 4 weeks. With laparoscopy, we can wait a little bit more if the liver is not as hypertrophied as necessary. So in this case, we could wait 4 weeks because of the laparoscopy in the first stage helps us. We always do a Glissonia approach for the second stage. We can dissect here the right Glissonia pedicle. After that, we staple the right pedicle. And then we resect a little bit of the liver, and then we complete the operation with transecting the right hepatic vein. So this is the second time. The second stage usually is not so big, not so large operation, not so time consuming, because most of the resection was already done in the first stage. So this is the final view, and this is the after the CT scan made after the operation. And then we changed some kinds of ALPs. We did some monosegmental ALPs. We did some, as we called, reversal or reversed ALPs, when we left the future liver remnant, just the posterior part of the liver. And we have some combinations of this. And about 5 years ago, we made a transition from open to laparoscopy. When we were gaining more experience with laparoscopy ALPs, we started to do more and more ALPs by minimally invasive. And this was our first report of minimally invasive ALPs. At that time, we had 20 open and 10 laparoscopy. And you could see that this is our experience at the time. And you could see that the patients has the same characteristics as open and lap. But when you see the results, you could see that we have less blood loss in the laparoscopy than the open, and also less complications when we compare the laparoscopy with the open patients. So at that time, we published we have less blood loss, shorter hospital stay, less complications, and less post-hepatectomy liver failure and infection in patients that undergone laparoscopic ALPs. But what about robotic ALPs? Well, for the last 4 years, we started to do robotic in most of our minimally invasive HPB surgery. But our colleague Vicente in Spain published the first ALPS procedure using a total robotic approach. And with our, as long as we are gaining more and more experience with robotic liver resection for right, left, and so on, we increased our experience with robotic. We published this some years ago with our first 50 cases, and then we started to do some robotic ALPs too. So this is the trocar positions. We put in straight line for robotic trocars and one for auxiliary 12 millimeter parts. So this is the first stage. We dissect the right portal vein with robotic. We can see clear view of the left portal vein here. We do of course the intraoperative ultrasound, and we can find the lesion on the left lobe, so we can remove it. So these patients all have a metastasis on the future liver remnant. So we have 4 metastases here, 2 contiguous one. We're going to resect them at the same time. Another one here, close to the pedicle, and another one in the segment 2 near the diaphragm. So just showing how we do it with bipolar forceps, irrigation. At the end of resection, we just do a normal hemostasia. And then we do the departition along, in this case, along the falciform on the left side of the falciform ligament. We do the demarcation. And we perform our resection or transection, liver transection, using bipolar forceps with a continuous saline irrigation done by the bed assistant surgeon. So we can see the final view. There are some resections. You can see some ischemic part of the left lobe at the time. And then this is the final view. And at the end of operation, we do our ligature of the right portal vein. And this is, we put some hemostatic tissue in between. This is the second stage. You can see that there is not much adhesions. So, but we always have this kind of liquid between both sides of the liver, bipartition. They have liver necrosis from segment 4, usually. Then we mobilize in the right liver. And because of the hepatic hilum was completely dissected from the first stage, usually we do a Gleasonian approach for the right pedicle. So this is the 2 incisions, as we already published this technique we put a vascular clamp just to make sure we are in the right place. At that time, you're gonna see we have a clear ischemic line, but we are checked with ICG because it's beautiful. We could see, of course, that it was already in a good place, but anyway, we can assure that with ICG. Multiple metastases on the right liver. Then we replace by a stapler, a vascular stapler, we clamp, we fire the stapler. And then we complete the mobilization of the right liver from above and from below. Sometimes we put a tape around the liver so we can use this as a hanging liver. With the robotic arm, we have a third arm that can keep the liver up. And then finally, we dissect the right hepatic vein, and then we're going to staple this with vascular cartridge, vascular load, and then we finish. This is the final view. The liver is removed. We check for bleeding by leak. You can see that the left liver recover from this ischemic area that I showed in the first stage. We can see that the liver you can see that it's no more ischemic, just more an hematoma in the liver than a real ischemic. So in conclusion, I think I have a good time. That's why I speak some fast. So like take-home messages like that minimally invasive ALPS is not only feasible, but also it does not appear inferior to open ALPS, maybe better. We don't have, of course, any comparison randomized to state it, but maybe better. In selected patients, he's possibly less operative severity than the OPA variant. And one important thing, then we can wait longer time to do the second stage because laparoscopy does not occur in more adhesions, and so the second stage is going to be much faster, much better than when we do open operations. And finally, today it's done in only few centers, but I think that with the robotic approach, we may expand the use of minimally invasive technique in ALPS. So thank you very much for your attention.
Thank you, Marcel. Those were excellent videos and certainly will lead to some discussion. Before we proceed to the next talk, I'm looking out into the room, and on behalf of the ILS Society, we are having a membership drive. So I think about 2/3 of you in the audience are not members of ILS. It's the International Laparoscopic Liver Society, and we would really like everybody to join. So the initials are ILLS Society, and you could Google that. And right now, we've initiated a very strong discount. So for anyone at your program who is a member, any of your trainees, the fellows or residents, it's only $20 to join. So, you know, we have to charge something, but that won't bankrupt even a resident. So please go back and have your trainees join. Now, if you're from a low-resource country, and it's nice to see we have some members from some low-resource countries, we've discounted 75%. It's only $50 to join. So a full membership is $200 per year, but low-resource country $50, trainee $20. And I can say, because it's already April in this year, I'm going to take the presidential executive privilege. If you want to join now for this year, we'll give you a 50% discount. So now we have no excuse. The meeting management are Margie and Jill, who are here co-managing this meeting, and they're out there, but you can email me or you can go to the website. So if you want to join as a new member and you're not low resource, then only $100, you get a 50% discount. So it's very modest to join, But what do you get by joining? Besides coming to our meeting, we have an entire website of hundreds of these videos that you've seen here, but you have to have a membership password. So, for example, we just had the virtual meeting where we had 86 countries represented and 1,350 registrants and 400 abstracts and videos. All of that content is uploaded to the website. So you can join now, and you can go and look at the entire virtual meeting if you missed it in person and download all of those from the website. Plus, we have some historical videos loaded from the, not all, but some from Paris and Tokyo meetings. So please join. The society is growing. We have over 400 members, and you can see that this session is well attended. So that's my pitch as for our membership drive. Our next two speakers, hopefully they're connecting. Do we have Zoom connection, or do we have pre-recorded for the next speaker, posterior superior segments, Mo Abu Halal? Yes? Is he Zoom call or pre-recorded? Video. Okay, excellent. So Mo unfortunately couldn't make it because he had a shoulder injury and had to have some arthroscopic surgery, but he's recovered. He sends his regards. And he's our president-elect for the IL Society. So Professor Mo Abu Halal from Brescia, Italy. Let's roll his video, please.
Good afternoon, ladies and gentlemen. And good afternoon, friends from the IHBB and from ILS. First of all, I'm really sorry not to be with you today, but this is because of good health reasons. I hope to see you soon another occasion. I have to say that I have no conflict of interest, and thank you for asking me to talk about laparoscopic resection for lesions in the posterior segments. This has been always a topic of hot debate due to the difficulty in dealing with these segments from a decisional point of view, but also from a technical point of view, having these segments in the posterior and high aspect of the liver, behind the ribs, close to the diaphragm. So this will make the access and the exposure of these segments and the lesions in these segments difficult. In the beginning of the history of laparoscopic liver surgery, slightly these were contraindicated, and I remember being invited to many meetings talking about the non-laparoscopic segments. However, the feasibility in experts' hands has been proved, and with time we demonstrated that these can be approached laparoscopically, and actually in recent studies, these are the segments which benefits more from the minimally invasive approach. They were considered something like laparoscopic major hepatectomies in the Louisville consensus. We done a study to look into that, and we agree that these are not minor hepatectomies, even if you are taking making a metastasectomy or a segmentectomy in segment 4A, 7, and 8. But they can't, we think, be called major hepatectomies. Hence, we came with the definition of technically major liver resections, because they are major from the technical point of view and not from the anatomical point of view. We documented the similarity, some similarities with the major resections in the outcome and some similarities with the minor, which makes them stand as a category by themselves. Now, parenchyma-sparing surgery in liver surgery, especially when we deal with colorectal liver metastasis, has been supported and advocated for a lot in recent years. And for this, we have proposed our technique, which is the diamond technique, which we believe can be, which is feasible. It's an elegant technique, it's fine, safe, and can be reproduced. But the most important thing, that it is oncologically efficient when dealing with with lesions in these segments. The technique was revised and reappraised again in 2020, and in this publication we have highlighted the pillars, the most important pillars of this technique, which are 8, with the most important being the use of straight lines and the thorough mobilization. All the pillars are important, but the use of straight lines and the thorough mobilization of the liver appears to us to be very important. In this video, we show you just quickly, for example, a lesion like this, and these are the straight lines. And we think the straight lines are very important because a surgeon laparoscopically can follow straight lines much better than circles. While following circles leads maybe to go into the center of the specimen nearer to the tumor. Straight lines, the mistake laparoscopically or the pitfall that you can go ahead or behind of the line, which is not a problem. And also considering that all our instruments are rigid and find it difficult to make curves, we think that straight lines for the instrument is much easier, and for the surgeon, it's much easier to handle the instruments. You can see also the stitches which we put, this is one of the other pilar, on the top of the specimen away from the tumor, which permits lifting the specimen and having a good access to the inferior part of the resection, which sometimes you have to dive in about 6-7 centimeters. And you can see the importance of a dry field in this setting because of so the Bringle, the good surgery, the meticulous dissection. Otherwise, in these tunnels, if you end up with a pool of blood, then you can't see. And we go on all the sides in different ways to all the sides simultaneously to be able not to fracture the specimen. And we take it out as a shape of a semi-diamond. Due to time, I will not go much in the video, but I will talk about the posterior segments, and I will give you the example of segment 7, having talked about the thorough mobilization. You see, it's a close to the diaphragm under the ribs. It's considered one of the most difficult segments. When we saw different publications from other groups, which regarding the position of the patient and the between the ribs, the transthoracic and the pores between the ribs, we were a little bit confused because looking at our experience, we have published this in 2013, and having videoed all our operations, we went to look at it and we found that we never have to go through the ribs or through the diaphragm. So we revised our experience, our technique, and put a lot of effort on abrasing it. And this is the way we put our patients. We lift the right side up. And here we started asking ourselves, do we really do segment 7 resections, or do we manage lesions in segment 7? And we find that we don't actually, because with the thorough mobilization and the rotation of the liver toward the left side, pulling the liver also to the left leg of the patient, we rotate that liver in making that the segment 7, where the lesion is, takes the topographic place of segment 6. So 7 becomes 6. And this was the trick in operating segment 7 without having to go to segment 7. So we don't go to segment 7, but segment 7 goes to us. Similarly, with segment 8, a thorough mobilization will enable you to pull the liver from the falciform ligament between the legs toward in direction between the legs of the patient, not rotating it. And that it brings segment 8 to a topographical area which lies between segment 8 and 5. So 8 becomes perhaps 5.5 if we want to just use this, this metaphor. So obviously, we acknowledge that there are very important techniques for anatomical resections, which we use sometimes following the veins and the vein route. This is in the publication of 2020 with the group from Professor Fernando and from Professor from Spain. And I'm sure all of you know these techniques, and also there are the extraglissonian techniques, which are, I think, very well represented in this beautiful work from Gianmauro Berardi, working with Professor Wakabayashi in Spain. So it's worth also having at these other techniques. being talking about segments, I have to tell you about the orange segments study, which have completed we have been completed 6 months ago, and we are collecting the data to publish the results. This has been comparing in a randomized fashion laparoscopic versus open liver resections for lesions in segment 7, 8, and 4A with the participation of a number of European centers. This has been concluded in November 2021, 250 patients. I can anticipate for the honor of ills just a little bit of the patient characteristics. So we find that the median age of patients was 68. The majority of the lesions were segment 7, followed by segment 8, then 4A, and some resection were done as 6, 7 as per the protocol of the study. The majority were colorectal liver metastasis. Understandable that this trial been run in Europe. However, we have a good number of HCC and cholangio and others. The other trial which is ongoing, which is the LivaCore trial, which compare colon and liver segmental resections done together or separate. So that will have a little bit of segments in the posterior section. It has started with the participation of a number of centers across Europe. So if you are not in this study, please contact me to join, because we are only starting and we had recruited 6 patients in the last 2 months, and we still have to go to 82 patients. Last but not least, being HPB surgeons, in this session, I would like to invite you to this important event where it will be the first internationally validated European guidelines of minimally invasive pancreatic surgery, which will take place in Brescia in the 29th and 30th of October, preceded by an EHPBA Gold course and followed by the opportunity to set the European board of HPB organized by the UEMS and the EHPBA. Many thanks for your attendance, and I have to say that the laparoscopic resection for lesions in the posterior segments is possible, that the diamond technique can facilitate that. We acknowledge that there are also the anatomical resections, and surgeons should be aware of all these techniques and may be able to do all of them. Thank you, and have a good day and a good meeting.
Thank you. Dr. Abu Halal is logged on, so he hopefully can participate in the discussion. Can we have the next video, please? Do we have the gender diversity and training? Yes, please roll the video from Catherine Tay, who's the president of Philippines HPB Society, and she's going to speak on gender diversity and training in HPB, laparoscopic liver surgery.
Thank you for this opportunity to talk about gender diversity and training in minimally invasive liver surgery. It's very sad that I cannot join everyone personally today. My name is Catherine Tay, and I'm sending this recording from the Philippines. It is very obvious that HPB is male-dominated, and Professor Kokudo showed this in his presidential address in April 2019, which is truly an indication of how HPB surgery started in Asia. True for other regions as well. The roster of IHPBA leaders were all men who brought HPB to the next frontier. It's very striking as well in ILS, where the proponents who are innovators and pioneers of minimally invasive liver surgery in the world are all men. Last year in the APHPBA Congress, it was reported that women clearly are a minority. The gender disparity is greatest in Asia Pacific, with only 8.8% women. Despite the paucity of published data, it is clear that women and Black and minority ethnic groups in economically challenged countries are significantly underrepresented. Although there is a significant gender gap in HPB, we are seeing the rise of women, albeit slowly, from 2% in 2004 to 17.6% in 2021. And in ILS, when we started at less than 1% back in 2017, we are now at 6% in 5 years. Taking on a global perspective, the Gender Gap Report of 2021 showed that it will take over 150 years to close the gender gap globally in all industries. What more in our surgical field at the rate we are going? This forms the gender stereotypes that is very evident early as expressed by medical students who were discouraged to do surgery. Even a recent report showed 72% of microaggressions, but only 7% of these were reported, with contents related to sex, race, or ethnicity, and even ascription of intelligence. Unfortunately, we also experience this amongst colleagues and members of our international societies, such that imposter syndrome, innovator biases, and feeling of exclusion exists amongst women and minorities in our fields of specialty because this is perceived to be a boys' club. Several papers recently indulged in a conscious effort to look into gender gap issues in HPV. Although there seems to be a pipeline problem, there is even more evidence with a paucity of data on women HPV surgeons performing minimally invasive liver surgeries, including the lack of women authorship in this subject. Although women appear as first and second authors in approximately one-fourth of publications, women make up only 1% of senior authorship. Majority of publications come from the West or high-income countries in Asia like Japan, Korea, and Singapore, which highlights the need for support for the minorities, especially the low and middle income countries. Apart from the inherent lack of female faculty and leaders, language barrier, cultural differences, and clinical workload has pushed our research potential in the back seat. Likewise, research outputs have been limited to local publications due to significant discrimination with outcomes reporting that appear to be unnovel. Sample size are said to be limited and other issues that are difficult to address in our poor healthcare systems. This highlights the need for support for the minorities. We do have a lot of catching up to do since the pioneers and innovators in the field were male dominant or coming from the West and those from high income developed countries, not to forget the implicit bias that is inherent. Back in 2016, Rebecca Minter initiated a gathering of HPB women in Sao Paulo, and the succeeding year, I organized a panel discussion on the challenges of women, both Eastern and Western perspectives, at the APHPBA in Japan. These were milestones that ignited the awareness of the gender gap. Last year, a very important step was appointment of Rebecca Minter as the diversity champion, and also the creation of an early career group in IHPBA with an intention to support gender equity, diversity, and inclusion. While the landscape in advanced minimally invasive liver surgery is evolving with the birth of ILS in 2016, females have not really taken an active role until recently. Under the leadership of David Geller, we recognize the need to encourage more women into mills and create a committee to promote diversity. Specifically, we aim to promote allyship, coaching, and mentorship by creating opportunities for exchange and collaborative learning. With 2 additional women in the council, we have formed a committee to promote women in HPB and find ways to bridge this gap. A survey sent out in 2019 and 2021 described the challenges faced by women in Southeast Asia, with childcare and family matters rated highest, followed by insufficient exposure and training in lap liver. A second survey involved both men and women, suggested that apart from being given equal opportunities and flexibility at work, we should also measure and report progresses to achieve gender development, seek family and social support to achieve their goals. Role modeling, mentorship, and sponsorship will make a big difference when we encourage people to proactively reach out and help others. Diversity and gender development must be deliberate and goal directed. For example, during the ASEAN LHC, which by the way is the first international HPV conference held virtually in August 2020 amidst the height of pandemic, this as the Congress chair, I made sure that we included women, early career surgeons, different nationalities, ethnicity, or economic status as faculty. We must learn from various advocacies and industries, from qualitative to quantitative research output showing how diverse surgical workforce eliminates disparities in healthcare, improves outcomes, and even innovations. We must find ways to support work-life balance, promote women in leadership and academia, provide mentorship, and offer childcare support even. Although many people are worried that as more women enter the workforce, studies show otherwise. Here I have outlined specific interventions corresponding to each categorical barrier, but in the interest of time, I won't really be able to go through all of them. But in a nutshell, we need to cultivate a culture of respect, respecting that each one of us is unique and each one of us may have something to bring to the table. Let us look at the different scenarios to illustrate these points. When there is equity and inclusion but no diversity, no new perspectives are heard.
Consensus guidelines are established and implemented, benefiting the interests of those in power. Innovation slows down without diverse perspectives. When there is diversity and inclusion without equity, we may be excitingly advocating for meals, but we are actually the minority who do not represent the bigger diverse community that has no access to these advances in technology. We do not see their needs. When there is equity and diversity without inclusion, which is probably the worst of all scenarios, yet difficult to explain, this is when someone has fresh, diverse perspectives, yet their ideas are not heard or misunderstood until someone dominant claims it and recognizes it as their own idea. As a result, the feeling of non-belongingness is evident. Many of us may have been in this situation many times. Men and women need to develop the confidence to have a voice that is heard and the determination to give opinions that should matter. Belongingness is the outcome of holding space where everyone truly feels empowered to speak up, make change, and shift the culture. And it is our responsibility as leaders to create these conditions. Again, borrowing from the business world, studies have shown that single incidents of exclusion can lead to immediate 25% decline in an individual's performance on a team project, while belongingness can lead to an estimated 56% increase in job performance. The Philippines has a Magna Carta for women, which is a comprehensive women's rights law that seeks to eliminate discrimination through recognition, protection, fulfillment, and promotion of the rights of Filipinas. So this also defines the Gender and Development Committee in every institution to promote women as partners in nation building. In our setting, 10% of our overall budget is allowed for any project pertaining to gender and diversity development. Apart from gender, we must not forget that diversity comes from different forms, and in an organization, it is a sign of progressiveness. This means that we value each one's opinion and are seriously committing to improve our vision. Last year, during my term as president at the PAHPBS, I've initiated new categories of memberships to include hepatologists, oncologists, and many other societies, specialties, and even non-MDs, such as nurses and patient advocates. By doing so, multidisciplinary nature of treating HPV diseases is more accessible and patient voices are heard as well. Learning and partnership with different societies, sharing experiences and resources will generate diversity and harmony, improve relationships, and implement allyship. This study shows that trainees with HPV and MIS training are more comfortable in performing minimally invasive hepatectomies and PDs as well. Based on two studies looking at perspectives from Canada and one from Southeast Asia, approximately 70% of respondents are comfortable doing lap, wedge, and minor hepatectomies, while more than 80% feel that they need more training and want to improve their lap HPV skills. This survey shows the barriers to expanding lap liver in Canada are mostly related to institutional factors such as overtime constraints and lack of instruments, followed by lack of training. And this seems to be universal because in Southeast Asia, we have the same barriers from our survey. And team training as well was a common barrier, highlighting the needs for non-technical skills training to ensure good outcomes from a high-performing team. Thus, these gaps not only in diversity and gender development, but issues in gaps in training must also be addressed. I'll say this group highlight the importance of training and mentoring in the acquisition of lab skills, and the reduction in learning curve was seen as to be proportional to the exposure of the trainee to laparoscopic liver resection, and the authors would advocate a fellowship as the gold standard of training. All the results of this study demonstrates two performance change points in both pioneering and early adapters group. Closer examination also shows that there were more anatomical major resections performed by the pioneering surgeons compared with the early adapters, and procedures performed by the pioneering surgeons after 150 procedures were more difficult than those performed by the early adapters after 46 cases. Thus, additional training in other centers with good courses and reliable faculties are adjuncts to formal lab HPV training. Needless to say, the more we practice, the better we get. So the ability to acquire these skills requires consistent practice, and evidence suggests that many of these technical skills can be learned away from the operating theater. This enables better patient safety and standards of care. However, there are some drawbacks for the animal or soft cadaveric model because there are no feedback mechanisms. Experiential learning might actually be appropriate in lab HPB training to bridge conceptual knowledge with skills that are tailored to the real world. It provides several benefits, in which 75% of knowledge learned through experiential versus 5% of conventional learning can be achieved. The ILS Laparoscopic Liver Surgery Fellow Skills curriculum was designed to assist with training in LLR in the context of a 2 years fellowship. This will be a good blueprint guiding the trainer because the curriculum aims to improve laparoscopic skills. But other skills such as oncological concepts, anatomical knowledge, or complication management must also be developed. Thus, these perhaps can be taken as an additional training to general HPV training. Although we know that technical expertise comes with practice and mastery, which Gladwell has elaborated in the 10,000 hours of practice as one factor that spells out success, he also stated that parentage and patronage were clearly beneficiaries of hidden advantages and extraordinary opportunities, which leads them to success in other ways, in ways others cannot. This clearly highlights the role of fellowship, mentoring, surgical coaching, and sponsorship apart from diligence and commitment. Acknowledging potentials of the early career groups is also equally important. Just like my personal journey, which was prompted by the person sitting next to me in this inaugural meeting of ILS. If not for Professor Bismuth, who pushed me to pursue lap liver, I may not have been there nor here speaking to you today. Thus, it is so essential to surround yourself with people you can learn from, with individuals who are already where you want to be. Mentorship is important, especially for early career, while sponsorship plays a role in mid-career. A diverse faculty is needed to improve effective mentors and sponsors who can encourage medical students, residents, and fellows to pursue this field and help advance one's career. With increasing number of women in HPB, in mills, the presence of women leaders and mentors is correlated with improved representation of women and the minority. So why does diversity and training actually matter? Because a more diverse HPB surgical workforce makes HPB and minimally invasive liver surgery more accessible to the marginalized sector, shorter downtime, faster recovery, which improves quality of life, and faster return to work, which is more essential in a low-income sector. As HPV cancers and liver metastasis is projected to rise by at least 40% over the next 10 to 20 years, with majority from the low and middle income countries, and at least 25% coming from minority groups, it is imperative to expand a diverse workforce and strengthen training curriculum to meet the demands globally, making quality HPV surgery available and accessible to all. As future-minded leaders of our societies, we must ensure to provide equal opportunities in surgical care, education, research, and leadership to attract more female trainees and medical students to HPB and make minimally invasive liver surgery training available to the minority to expand this surgical modality. Avoid innovator biases that leads to imposter syndrome by being open to other concepts and perspectives. Recognize and appreciate a diverse faculty regardless of race, gender, culture, or economic status, and empower the minority to engage in issues and providing solutions. Lastly, we need to foster belongingness by all our actions. Finally, I'd like to look forward to the time when we can call ourselves leaders and not distinct ourselves as men or women, because we are all leaders already, pushing HPV to the next frontier, regardless of gender, embracing diversity, and future-proofing HPV training. Thank you very much for your attention.
Thank you very much, Catherine. In the interest of time, we need to move on to our last speaker. It's Dr. Iswanto Sukandi from Advent Health in Tampa, Florida. He'll be talking about robotic left hepatectomy and hepatojejunostomy for cholangiocarcinoma. Iswanto.
I would like to thank the organizing committee for the opportunity to present here. I have no disclosure. The only disclosure is I was trained by Dr. Geller in Pittsburgh during my fellowship 6.5 years ago. Talk about robotic left hepatectomy and hepatojejunostomy for cholangiocarcinoma. The technique is going to be in 12 steps, and we're going to go one by one. For the interest of time, we're going to dive to it right away. Can we go back to the video, please? The video is kind of long, so that's why I want to go straight to it. This is can you run the video, please? This is the 80-year-old man who presented to the hospital with jaundice and 6-centimeter liver tumor on the left side of the liver involving the left portal vein. And obviously, the patient is jaundice. It means there's some issue with the bile duct as well.
Can we start the video?
Can you run the video, please? Yeah, just click it. Jesus.
Do you have the video? No? Do you have a separate file?
Can you? I do have file. I do have in my flash drive.
Okay.
Can we do it now?
All right, we're going to upload the flash drive. You don't have the video separately, the AV team? He'll give you a flash drive. We have a few minutes extra because we have some discussion built in. The session's scheduled to end at 5:45. While we're waiting, you can go on the website and register for ILS membership. You only need your name, email, country, and credit card number. Also, while we're waiting, we have a robotics. If those of you interested in robotic liver surgery, there's a robotic webinar scheduled in a month. And the registration is free for that. You can just go to the ILS website. We already have 75 people registered for the webinar. It's a 90-minute webinar. But some of the speakers are in the room here, and it's phenomenal state-of-the-art lecture. It's free to everyone. Even if you're not a member of ILS, you can participate in the robotics webinar. So you can just go to the website, and that's advertised there, and you click register, and you're in. Are we good back there with the video, Iswanto? Okay, let's roll the video if we have it. Okay.
This video has been about a year and a half ago, so it's not super new video. So you can see here there's a big tumor on the left side of the liver involving the left portal vein, which is occluded. You can see there, and the patient came with jaundice. There is a biliary stent going to the right side of the liver. So you can see here, this is the first liver mobilization here. This is robotic approach, 5 ports. And our technique actually has been published before for robotic approach. And you can see here the hepatocaval confluence is being dissected. And this is quite easily done with a robotic technique. Important part of the operation is always portal lymphadenectomy. So I intentionally spend about 45 minutes doing a portal lymphadenectomy in order to maximize the oncological clearance of this periportal lymph node. I routinely cauterize the duodenum widely in order to flip the porta hepatis to the right side. So then the portal vein is looking at the 9 o'clock instead of 6 o'clock. So you can see here the cholecystectomy is done. Mainly the section is done with hook cautery. Cholecystectomy is done in standard fashion. You can see here we remove the cholecystectomy with specimen removal. So now this is the common hepatic artery being dissected from the proper hepatic artery, and we were moving toward the celiac. This can be done very easily with the robotic system, and we are trying to really spend time for this. The section starting from the caudal and moving toward the hilar plate, there's always small branches that coming out of the hepatic artery. It can be easily clipped, and I always have emergency stitches ready, which is basically 5-0 or 4-0 Prolene on a CV23 needle. So you can see here the portal lymphadenectomy is done, and we're skeletonizing the bile duct. This is the tissue between the proper hepatic artery and the bile duct. And you can see here, once we disconnect the bile duct, we will have full access to the lymph node on the posterior aspect of the hepatorenal ligament. This is the segment 4 hepatic artery. This is accessory, so being dissected. And you can see here, this is the left hepatic artery now being divided. Now, we are moving toward the bifurcation of the portal vein dissected as well. This is the inflow to the caudate. As you can see here, it's easily dissected with the hook artery. This is the operation with the en-bloc caudate resection. I utilize basically a bowel grasper to lift up the spiegel lobe. This will give us access to the piggyback from the left side. So now the short hepatic veins are being dissected mainly with the hook. I usually dissected them at once, 3 or 4, in order to save time. So I feel like it's wasting a lot of time if you have to get the instrument in and out with each of the branches. So I dissected all of them and clip all of them and cut all of them at once, obviously as much as possible. So now the dissection continue, and you can see here the same maneuver that I mentioned before. The liver side, I just use the energy, and it's quite safe. It doesn't bleed. Now we have a little hole in the cava, not a big deal. This is easily controlled with the robotic system. We have not opened any patient with the cava bleeding, even though we make a few holes in the cava before. And this is just a monofilament suture. So now we keep going. So the cava hole is fixed. So now the caudate is freed up all the way to the caudate extension. So the paracaval is coming out all the way. So this is a skeletonization of the retrohepatic cava from the foramen of Winslow up to the hepatic veins entrance into the SVC. I think it's important to spend time to really maximize the mobilization here. It will make the operation easier later. We utilize a low CVP and central line still for the major resection here. So now we cut the distal bile duct flush to the head of the pancreas. We take a distal margin. This is a routine procedure. Now, in order to provide traction and also to limit the bile leak, I close the bile duct end. And you can see here we continue to do a portal lymphadenectomy. You see that we enter the foramen of Winslow very clearly there. We go down as much as possible into the back of the pancreas. Sometimes there are small vessels here. You can easily clipped or taken out with the vessel sealer. Now, we are moving toward the hilar plate. They usually segment 6 branch here. It can be easily managed as well. This is a small branch of the right hepatic artery going to the back of the common hepatic duct. It can easily control as well. So now we are exposing the portal vein bifurcation. You can see here the right hepatic artery is now out of the way because the left has been cut. There is actually a tumor thrombus on the left portal vein. So you can see here I pass a 6-inch silk suture. Thank God, I think we still have enough space to place a ligation here and still obtain a negative margin. If not, then I'm going to usually place a bulldog and open the bifurcation and suture across the bifurcation. This is a very common maneuver. I like the vascular bulldog. They can be easily placed on the portal vein, and even if there's no clip there and portal vein is open, it can easily be repaired as well. This is just like removing a thrombectomy or any clot from the bifurcation. And now with the portal vein now also detached from the left side of the liver, You can rotate the whole portal hepatis to the right side of the liver, and then now you're having a very good access there. Now we're dissecting the hepatic duct now. I'm trying to use ICG, but I think it's too bright. There is a way to tone down the ICG on the robot, actually. So now this is the left hemihepatectomy and block with a caudate. We're marking on the liver parenchyma. We mainly utilize a crash clamp technique. This was not done with the Pringle. Of course, can be Pringle, but sometimes I don't think it's necessary to do it. So now this is a small branches that is controlled with a clip. Now we're exposing the left bile duct. This is, I think, is important to really see where the bile duct is located. We use a hemostatic agent as necessary. Now this is the bile duct, and this is my favorite step when we cut the bile duct and the bile is pouring out like that. So it feels like relief, you know. So this is a bigger collaterals going to the segment 4B, and now we are finishing up the left hepatectomy now. This is the left hepatic vein being stapled flush to the cava, you can see here. The assistant is basically holding a suction for saline injection. This is a picture-in-picture with the Boston Scientific spyglass. I like to do this to look at the remaining part of the bile duct. Now, we are high now up to the secondary radical. You can see the right posterior, right anterior are split. It's about a centimeter distance. I utilize a monofilament 5-0 suture to put them together in order to do a single anastomosis. We have done 2 anastomosis, but I think single is easier. Typically 3 sutures just to put them together. We make sure the knot is on the outside. And this is essentially a regular reconstruction hepatocystinostomy now. You know, this hepatocystinostomy, we're using the same principle as a Whipple operation, except this is much harder to do, by the way. Whipple is relatively easy to do bile duct anastomosis because it's much lower. This is where we train our fellow to do the suturing on the robot. This is a standard staple side-to-side jejunal take about maybe 15 minutes to do. Fellow doing probably extra 10 minutes or so, but it is a good experience for them. A small opening is made for the hepatocystinostomy. It is important for the assistant to push up the root limb in order to take away the tension of the root limb, because the first 2 stitches are very key. If the assistant is not pushing up the root limb, sometimes you tear the bile duct at the 9 o'clock location. Now, I usually like to do just running suture. This is the front wall now. We always do the back wall first and then go to the front wall later. The patient is actually doing quite well. Discharge on postop day 6. Pathology, intrahepatic cholangiocarcinoma with negative margins. Very quickly, just to share with you, we actually published our CladScan resection. This is not quite CladScan, but I just want to share a little bit. This is a 20 CladScan tumor we have done in our program. And you can see here the operative time is about almost 8 hours each of them. You can see here a CladScan type 1 to 4. The margin status lymph node harvest is 6. And they actually do quite well. Thank you very much.
Thank you very much. Outstanding technique. So if anyone, in the interest of time, it's exactly 5:45, so I think we'll have to forego discussion, but if there's any 1 or 2 pressing questions, you can come to the mic and the panels can answer them. Okay, if not, then I know people are tired, the day hour is late, so thank you very much, and we'll see you at the ILS 2023 Rome meeting in September 13 to 15, Rome, Italy. Thank you very much.